Hi, this is Dr. Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer. And today I have the great pleasure of speaking with Dr. Teresa Pan, who is in the Department of Obstetrics and Gynecology at the Medical University of Innsbruck in Innsbruck, Austria. Teresa is a dear friend and colleague and also a collaborator, and she's also a former fellow of the International Journal of Gynecological Cancer. And the topic of this discussion is a manuscript that we actually both worked on. So we're extremely proud of the work that she had done and the work that she has led to complete this study. The study is titled Accuracy of Preoperative Tumor Size Assessment Compared to Final Pathology and Frequency of Adjuvant Treatment in Patients with FIGO 2018 Stage 1B2 Cervical Cancer. Tere, welcome to the podcast. It's so great to see you, and thank you for the opportunity to discuss this manuscript and accepting our invitation.
Yeah. Hello, Pedro. Hello, everyone. Thank you very much for this invitation. I'm super thrilled and honored to be here, and I'm excited to talk about our paper.
Excellent. So I wanted to start by recognizing, obviously, that there has been a great deal of new data for the surgical management of patients with early cervical cancer. And some might argue that the indications for radical hysterectomy are continuing to decrease. Now, you were particularly interested in patients with tumors 2 to 4 centimeters. What was the rationale for putting together this study?
So thank you for the first question. So historically, we know that high morbidities are associated with combining multiple treatments, for example, as surgical treatment with radiation therapy or chemoradiation. And even though if these morbidities are decreasing with new techniques and new technology, there is still a high risk of complication when patients undergo combined treatment. And as stated in the question itself, there is a tendency to reduce radical surgery, and it's widely debated for really early cervical cancer, but also now for more locally advanced surgical cancer. And there are even studies now looking at fertility-sparing treatments in patients with tumor size bigger than 2 centimeters. On the other hand, we have data knowing that these patients often have high risk factors and they tend to undergo maybe combined treatment. So considering this wide range of therapeutic option, which is being discussed for this group of patients, it is crucial to know which preoperative staging method is the best for these kind of patients to know what we're talking about. And I think for all these reasons together, we focused on this specific group.
Excellent. So thank you for that introduction. And to that point, I want to just follow up. What do you consider are like the best strategies for the preoperative workup of patients being considered for radical hysterectomy?
Yeah, I think in this case, it's always good to rely on international guidelines, and they, according to the recent European ESGO-ASTRO-SP guidelines from 2023, so the update is only from last year, it's always written that the preoperative workup should include MRI. So they use the term mandatory. And ideally, I would add it's good to have a specialized radiologist looking at this MRI. And I would say that our data confirms this kind of recommendation, as we see that there is a high concordance between MRI, like tumor assessment through MRI and postoperatively through pathologic evaluation. And in our numbers, for example, we see that specifically for this group 2 to 4 centimeter, the concordance is over 80% for these patients. And I think this is crucial. Furthermore, if we look for the stratification, so smaller than 2 to 4, bigger than 4, so the 1B subgroup classification, the concordance is at about 86%. So I think MRI, as the guidelines state, is definitely recommended and the best strategy probably.
Okay, great. So let's start getting into this study. Tell us about your study design and your inclusion and exclusion criteria. What was your primary objective?
Yeah, so we had a great opportunity to make a retrospective data analysis, including patients from 3 different internationally recognized databases from 3 different study groups. So we used the MD Anderson Cancer Center Radical Hysterectomy database, the Sucker Study Group database from Luis Chiva, led by Luis Chiva, and the Latin Multi-Institutional Database, which included patients from Latin America and Europe. We included all patients who preoperatively have been stage FIGO 2018, stage 1B2, and who underwent a radical hysterectomy with a curative intent. Patients who were classified with previous FIGOS classification had to be reclassified according to the 2018 staging system. And about the histology, we included squamous carcinoma, adenocarcinoma, and adenosquamous carcinoma. Preoperative assessment had to be with physical examination and or imaging. And imaging included ultrasound, MRI, CT, or PET-CT. So even if the patient has just one of these preoperative assessment, they were included. And the tumor had to be considered over 2 centimeters by at least one of these assessments, because there are some patients with more than one assessment tool. Exclusion were made for patients where, of course, we had incomplete data collection, who were pregnant, who received a neoadjuvant therapy, who underwent prior conization, or where there were missing information about postoperative tumor size. Our primary endpoint or primary aim of our study was to assess the concordance between the different imaging tools, preoperative size assessment with tumor size on final pathology. And as secondary outcomes, we aim to evaluate the rate overall of adjuvant treatment, and we did a specific subgroup analysis to see how the tumors behave when they're not only 1B2, but 1B2 bigger than 3 centimeters.
Excellent. So before we get into the results, one thing that I certainly want to congratulate you on is the fact that bringing together numerous centers, collecting all of this data, obviously poses many challenges. What are some of the barriers in doing this type of study, and what did you learn from it?
Yeah, thank you for this really thoughtful question. It was challenging. It took us over a year to complete the study, and this is primarily due to the challenges associated with the data collection, working with different databases from different countries, and over a quite extended period of time of almost 30 years, let's say, so starting from the 90s to nowadays. And during this time, also FIGO classification changed many times, new scientific knowledges were published, so some information were really hard to get for the older specimens or have to be readjusted to new staging systems. And also a problem is also one weakness or difficulty was their lack of standardized imaging protocols. So even we knew what kind of imaging was performed, we can not identify many times what kind of, for example, diffusion weight MRI was performed, what type of protocol, or how experienced were the ultrasonographer performing the ultrasound. And another major limitation or challenge, which we really focused on, but we were not able to identify in all the cases, were the indication for adjuvant treatment, which I think is inherent in the retrospective nature of our study, but of course is a question that comes up often. So it's challenging, and I would say that, of course, it's the value of the study is to have so many patients from different countries, also from different institutions, all recognized, but it was a challenge to put everything together with the little stand of knowledge.
Well, you did a magnificent job at that. So congratulations. So now let's get to the results of the study. What are the main points to highlight?
Yeah. So, of course, we cannot go through all the results in detail, but I'm happy to highlight some key findings. First of all, I want to emphasize on the large sample size, which are almost 700 patients. And about the histology, I was to know that the majority had squamous carcinoma. So this is what we find in literature. And for more detailed demographic data, I encourage you to refer to the manuscript directly. Regarding imaging, approximately 52% of the cohort underwent MRI, which is good. So that means we had a good portion of patients with the data about MRI. Some patients had multiple imaging modalities, and about 1/3 of patients had tumor size evaluation only by physical examination without imaging. I think the first key takeaway message is the high concordance. We already talked about it between MRI and final pathology being over 80%. Secondary, looking at the adjuvant treatment, we see that in the overall population, 51, so about half of the population received adjuvant treatment. the most common one being chemoradiation, followed by radiation alone. And the interesting thing is that in the median tumor size in the group receiving adjuvant treatment was 3.0 centimeter. So this is, I think, another key aspect, meaning that in this group, so whole group 1B2 preoperatively staged, half of patients underwent some kind of adjuvant treatment. When focusing on the subgroup analysis, so the tumors equally or bigger than 3 centimeter, we found that instead of 51%, 61% of patients received adjuvant treatment with distribution of adjuvant treatment type similar to the overall group. And when following this analysis, we see that when we go even bigger, so tumors over 3.5 centimeter, rate reaches almost 70%, highlighting how tumor size alone is a significant determinant for the use of combined therapies. Lastly, I think one interesting data is when comparing risk factors across the groups, across the same group, the same stage, better said, but dividing the group into bigger or smaller than 3 centimeters, the bigger tumors, so over 3 centimeters, showed a statistically significant higher incidence of positive lymph nodes, with 13% versus 21% being positive in the latter group.
Yeah, so really very interesting study and results. And as we say in the United States, perhaps opening a can of worms as it pertains to particularly those larger tumors, such a high number getting radiation therapy. So Tere, as you know, and you remember as being a fellow in the journal, now come the questions from the fellows. Elena Rodriguez from Spain, she asked, how was lymph node surgical assessment performed in patients included in the study? And do you think that systematic frozen section lymph node biopsy could reduce combined treatment in these patients?
So thank you, Elena, for this question. Unfortunately, we do not have a standardized approach for lymph node staging across the different cohorts, so it's difficult to address the first part of the question. But as the question is really interesting, I would like to make like an exercise of our minds. So we know from literature that approximately 50% of positive lymph nodes can be detected with frozen section. And different international guidelines recommend either frozen section for lymph node detection, or ideally a two-step approach. So not with frozen section, but histological evaluation, complete histological evaluation of the lymph node before determining the therapeutic pathway. In our study, we do not have details for the indication, but we know that overall in 13% of our cases, positive lymph nodes were detected. So if we hypothesize that with frozen section, approximately 7% would have been detected, maybe the rate of adjuvant treatment could have been lower, starting from 51% to maybe 44%. However, it is of course crucial to underline that these are only hypothetical deductions and not at all a scientific conclusion we can draw from our data. So interesting question, but we cannot answer that, definitely.
Very well. This next question comes from Ali Strovar in Salt Lake City. And you talked a little bit about it before. Is there a specific MRI protocol that you recommend?
Yeah, so thank you for this important question. We talked briefly about it earlier, is one of the limitations of our study. However, we know, and everybody knows, I think that there are still ongoing studies trying specifically to address this kind of question, mainly study conducted by radiologists who, of course, have more expertise than ourselves. And what is important to know is that there's currently no international recognized standard for MRI protocols worldwide in cervical cancer staging, and there's still a high variability exists between institutions. So this is definitely something to address, but I don't think that our paper can answer this question at all, unfortunately.
Okay. This one from Jose Carlos Vilches in Malaga that I know you know. His question is, given the advances in high-resolution ultrasound, do you think we will be able to replace MRI scans with good ultrasounds?
So this is an amazing question. And depending on whom you ask it, this question could probably spark a debate that lasts all night and all day and will get really intense. So let's start by acknowledging that there are studies in literature showing actually that with a highly trained ultrasonography, ultrasound is not inferior to MRI for evaluation of cervical cancer or for staging. And this might be particularly relevant in settings where MRI is not available or may not be accessible in the near future either. In our data, which included 140 patients who underwent preoperative ultrasound, the bias between ultrasound estimate and final pathology was not statistically significant. So this is the Bolt-Altman analysis, meaning that ultrasound did not significantly over or underestimate the tumor compared to pathology, and who's interested can have a look at its described in the supplementary table 1. However, I must say there are still a lot of challenges using ultrasound as standard of care. There's a high inter-observer variability, and there's a lack of widespread expertise. For these reasons, I don't believe that we are anywhere close to replacing MRI with ultrasound, and I really want to bring my highest respect and admiration for Professor Fischerova and Professor Testa and all their team and their work. But I think it's safe to stick with also here with the ASCO guidelines, where they define MRI as mandatory and ultrasonography as an option if performed properly by trained sonographer. So if it's a yes or no question, I would say for now, no.
Excellent. Now, this next question, Roberta Massobrio from Italy, and she asked, in your opinion, what is the optimal management for stage 1B2 tumors greater or equal to 3 centimeters? Should these tumors be treated still with radical surgery, despite the high likelihood of requiring adjuvant therapy, or should they be directly referred to chemoradiation?
So I really like this question because it's the kind of question I likely would have made myself when I was a fellow. And there's a retrospective study by Huang et al. Addresses this question directly and concluding, and here I quote what they write in the paper, concurrent chemoradiation therapy is a more appropriate choice for tumor sizes over 2.7 centimeter, end of quote. My answer, on the other hand, is that our retrospective data are, of course, insufficient to warrant any changes to therapeutic approaches recommended by current guidelines. However, these data, as the colleague saw, can raise the questions of whether therapeutic algorithms should differentiate even within the same FIGO stage. So while waiting for further results, what we can do is to explain our patient that although treatment might be intended as curative at the beginning, additional information gathered throughout the process may show the need for adjuvant treatment, and also to keep this in mind ourselves, so to assess patients' overall health to determine if they will be fit enough for eventually treated adjuvant treatment. Secondly, I think it's really important that to have the best possible preoperative staging, and this includes a good assessment tool. So particular care is especially needed in tumor size approaches to the boundary of their stage. And in such cases, for example, if one has limited resources of MRI, this would be a case where it's more important than in other cases to have a good tool, a reliable tool. And for example, in lymph node evaluation, it is particularly important also in the patients where the tumor size is at the boundary from one stage to another. This is also a case where I would recommend to pay a particular attention.
Now, Tere, this question is again from Elena Rodriguez, and she asks, did you compare risk factors between the group that did not receive adjuvant treatments and the group that did?
Yeah, that is an excellent question. I think we did not perform this analysis, but I really would like to do this analysis. We did not did it because it's like would be a sub-analysis in our subgroup analysis. But I would definitely like to look back at the data and get this information. So thank you for the input, Elena.
Excellent. Future study. So the next question is, in the results, of 340 patients who had tumor size on pathology greater than or equal to 3 centimeters, nearly 40% had no adjuvant therapy, but of 335 patients with tumor size on pathology less than 3 centimeters, 40% received adjuvant treatment. What criteria led to the decision to withhold adjuvant therapy in 40% of tumors measuring 3 centimeters or more?
That's an interesting question. Unfortunately, Ed noted also in the manuscript's limitation, we were unable to determine the exact indication for adjuvant treatment across the entire cohort. So we cannot explain why some population received adjuvant treatment and why in 40% of cases it was withheld. However, I want to emphasize that more concerning issue should be why 60% of patients who had already undergone radical surgery with all its associated risk and morbidity intended for a curative outcome still require additional treatment such as chemoradiation, adding further risk of side effects. So in my opinion, the focus should be less on questioning why 50% of patients were spared from combination of therapy and more why some patients needed both treatments, like most of the patients needed both treatment when ideally only one approach should suffice.
Excellent. So I want to jump to a question by Mine Dagis from Turkey. And she asked, do you believe that the set list criteria have become entirely irrelevant for this tumor subgroup? Should we prioritize assessing LBSI and deep stromal invasion prior to surgery instead of focusing solely on precise size measurements via imaging modalities or physical examination?
So thank you for this question. And I must say, I certainly do not believe that SEDLIs or other high-risk criteria are irrelevant, nor that only tumor size estimation should guide the therapeutic approach. And I really hope that this is not the message that our colleagues take from our paper. I do, however, believe that it is crucial to optimize preoperative size assessment as guidelines and recommendations are generally structured by stage. So a reliable tumor size estimation is essential for defining the patient's risk profile and is necessary as a first step. As a second step, it is maybe equally important to evaluate the risk factors as good as possible before surgery. In this regard, I mean assessing the risk factor not as secondary in terms of importance, but in secondary in terms of timing, chronologically, let's say. So for example, when I assess LVSI status, for example, it changes my specific management and I have to adjust it, but this depends primarily on the stage, because in an advanced stage, even with negative LVSI, I do not, some restrictive surgery are not feasible or not safe. So in this sense, I think that the order should be in our head and also in the diagnostic process.
Great. This question goes back to Roberta Masobrio, and she's asking, do you think that despite the introduction of accurate imaging for local regional staging, the decision for surgery should still be primarily guided by a physical exam?
So thank you, Roberta, for bringing up this controversial question. And I've really put some thought in that question because it seems easy, but it actually is not that easy if you look at the data. So in our cohort, for example, 39% of patients only underwent physical examination, and we still found a surprisingly high concordance of about 80% when comparing it with the final pathology, slightly lower depending on the histology. So we know from with adenocarcinoma and adenosquamous carcinoma, it's lower. The high concordance in our case might be explained by the fact that the institution, which mainly perform only physical examination due to lack of availability of imaging tools, are all specialized centers with high patient load. For example, we know that in 87%, the patients in the LATAM cohort only had physical examination without no imaging. Comparing it, for example, in the SUCCOR study group, which is a more European-based center, only 5% had only physical examination. So I think physical examination remains a crucial part of the clinical workup and can provide valuable information on parametrial invasion, for example, or tumor size. However, as all international guidelines emphasize, imaging tools should be relied upon for primary assessment and therapeutic planning. So also one thing to consider, this is more personal, but for example, for imaging tools, images can be shared and second opinions can be collected, overcoming physical distance, asking experts all around the world, and this is simply not feasible for physical examination, where there is no standardized protocol. There is a high variability, and of course, in institutions with less experience or less patients load, this can be a really risky tool. So I would not rely my therapeutic decision only on physical examination.
So I guess to that point, on the next question by Ali Strubhar, is she's asking, who do you recommend then should have a preoperative MRI? Absolutely, definitely.
So this question may seem straightforward to everyone. I recommend MRI for every woman with cervical cancer, especially considered for surgical treatment. However, in real life, and especially in low and middle income countries, which are the countries with the highest incidence of cervical cancer, this approach is often not feasible. So when MRI is not easily available, I maybe said this also earlier, but I would recommend reserving it for those patients and need the boundaries of their FIGO stages, or in cases where during the physical examination or even during the ultrasound, there are doubts coming up. Another scenario where I would rely on the best imaging tool for cervical cancer, for example, but I cannot do MRI for everybody, but I would really recommend to do it for the patients, either if they're not fit for combined treatment, so I don't want to risk that they underwent surgery and then still needed another adjuvant therapy, or because this is also really now a debate problem that has been debated in those patients who wish to preserve fertility. So in such cases, we have to be as sure as possible to know what we're dealing with. And for these cases, I would definitely try to get an MRI, even if it's a bit more difficult.
Excellent. So that as we come to the conclusions of the podcast, I want to ask you, what do you consider are the limitations of the study?
Yeah, it's important to address the limitations. I think we wrote quite a lot of them quite honestly in our paper. First of all, it's a retrospective data analysis, as we said in the beginning, and some of the data, some of the patients underwent surgery almost 28 years ago. So there might have been variation in this long time in terms of imaging quality, indications for adjuvant treatment as guideline changes, and the recommendation. The biggest flaw, I think the biggest information we all have been missing were the indication for hysterectomy and the indications for adjuvant treatment, which were not outlined and leave some questions unanswerable for now. And also one limitation is the variation in radiological estimation and also pathological interpretation of the actual tumor size. But this is all, I think, implicit in the retrospective nature of our study. It's hard to overcome.
So as you know, I ask all the authors as a last question, based on the findings in your study, how should we use this information to guide counseling and patient management?
So thank you for this question. I think it's an excellent question, and it's clinically so relevant, and it's what most of readers ask themselves after reading an article. So thank you for bringing it up as a final question. So I would say that at this point of knowledge, it's crucial to explain to the patient that although treatment may begin with a curative intent, it's a realistic scenario that after gathering more information with the specimen, with the pathological analysis, there will be need for adjuvant treatment. I think it's important also, as I said before, that knowing this scenario, keeping that in mind, you look at the patient as a whole, you explain to the patient this risk, and you always are also as sure as possible that the patients is fit enough to get through surgical treatment with the possibility of getting adjuvant treatment as well. I would also recommend to, while counseling the patient, to explain to the patients the limit of preoperative staging methods. We can explain to them, of course, that, for example, MRI is really, really good, has a concordance of over 90% in some cases, depending on the stage, but also that it is still just an estimation. And I think this is important for the patient to know and to keep in mind. And I think you need to have a good relationship with the patient, and I think then counseling goes well.
Tere, thank you so much for this opportunity to have an in-depth discussion into this paper. I want to also once again thank you and congratulate you for the amount of work that you have put into this manuscript, the amount of effort, the amount of time, and again for bringing together this opportunity to discuss this on our podcast.
Thank you. It was really fun. Thank you to all the fellows, and thank you to you, Pedro, for this opportunity.